All right, the day of the machine continues. We're going gastrointestinal part two, and I'm not even going to start talking. I'm just going to go. So, one, two, three, go. Let's do it. All right, celiac. So, celiac is a problem with gliadins, Gliadans. I think that's how that is. Gliadins. These guys, what happens to the intestines is it becomes a flat intestinal villi. And what does that mean? That means that the surface of the intestines usually is very bumpy. Remember, we have the villi and the microvilli, right? The big fingers and the little fingers, and they push things along, and there's little pads and there's ridges and things like that. It's not like flat. So when it does get flat, it becomes a flat slip and slide, basically. That's celiac. Hi, how's it going? Now are you seeing the picture? Now is that heads up display working? Oh, now it's working. Okay, cool. All right, so that's how that works. So, let's see. What is the antibody blood test is what you need to know, and that is the antinuclear antibody test. What else do I know about celiac? Oh, there is a type of symptom that you have with it. You get blister type bumps on your elbows and your knees, and that's called dermatitis hepatiformans. Sorry, hepatiformans. And that is an indicator that you obviously have this condition. In addition to that, geez, you have all kinds of symptoms, right? Like you'll have like unexpected weight loss, you'll have like mouth ulcers, you'll have like menstrual irregularities, enamel changes, inability to tolerate dairy products. All right, so what do we need to eat? Well, we can eat things like broccoli and meats and things like that. And rice is even a go. What is not a go? Well, duh, bread. You don't want to have a sandwich. Sandwiches are delicious, but sandwiches with a celiac is not delicious at all. As a matter of fact, I would want nothing to do with that if I were you. Gliadin. Let's see. So it is a plant storage protein and it's high in amino acids, particularly proline and glutamine, aka gluten, right? So that makes sense. So we would tell them to basically, I've told you the tests to check it, that's done. I've told you what the disease is, that's done. Recognizing it in a kid, aka with these spots or any of those other symptoms and signs, okay, done. And then how to fix it? Well, obviously avoid those foods, maintain a good diet. So know your diet. We talked about that. Done. Yeah, I think that's cool. I think that's groovy. All right, let's move on. All right, so let's quickly go through intestinal obstruction. So it's complicated. It can be partial. It can be complete. They could be a paralytic ileus. Like there, you can cause or you can create a cause for commotion to argue that a lot of things can be considered an intestinal obstruction. Here are the facts that you need to know. Something is blocking the way from it going through the pipeline. Period. So when that happens, we're physically blocked. It could be a tumor. It could be a fecal impaction. It could be an adhesion, it could be a fissure, it could be in the bowel wall, it could be Crohn's disease, it could be a lot of things, right? It could be a herniation. Usually over the age of 65, the most common cause for it is diverticulitis. That's when the diverticula kind of bulges and pouches out of the digestive tract and becomes inflamed or impacted. Appendicitis could be a reason. Crohn's disease restrictions or radiation treatments or anything like that. There's a lot of reasons. Um, so there's that, and then there's the non-mechanical version, which is a paralytic ileus, which is my intestine stop. So what do these things sound like? Well, it could sound like a variable. So sometimes there's very low sounds heard in one quadrant, and then the other are hyperactive. That's a good indicator of that being a thing. And I would probably remember that concomitant with like abdominal pain, right? Nausea, vomiting. Why is that? Because before the obstruction, everything's clogged, right? Because it's trying to push through, but the thing's in the way, right? And everything after, there's not a whole heck of a lot going on because it has been moving in theoretically sometimes days. So that's why when you have sounds over here and sounds over there, and it gets kind of wiki wonky, it's either going to do one or two things. It's going to get super hyperactive, albeit temporarily, trying to kind of speed up the process to get it through. That's a new obstruction. Or it's just going to sit there and it's not going to be a whole lot of anything at all. And that's when you know you have a big problem. That's when we talk about making sure we have bowel sounds. Because once it stops, it becomes ischemic, right? Because it's dying. It has a lack of oxygen. Anyway, so that's how that works. Usually related to intestinal obstruction in exams, this isn't a matter of you understanding the ins and outs of an intestinal obstruction or how to fix it or any of those things. With intestinal obstructions, we usually do bladder rest, bowel rest, which means that they aren't going to eat or drink anything for a minute. Sometimes we have to do nasogastric suction, yeah, well, that's right. We have to do like a traditional nasogastric suction to get all of the poop out, right? Depending on how bad it is. Sometimes we have to suck it out. And while we're doing that, we have to worry about electrolyte imbalances because, well, we're sucking it out of them. So they're losing it, right? Because they're not absorbing it because it hasn't gone all the way down the pipeline. So it can't. So there's a lot of things that you need to kind of be concerned with. Again, for these exams, you need to know the following: NPO status, IV fluids, electrolyte replacements, potentially TPN. Decompress the bowel. That's everything. Decompressing that bowel so that we don't perforate it is perfect. That's everything. That's why we stick in the nasogastric tube. We're going to throw it to wall suction, right? Intermittent. What else do I have? You need to try to move them. You need to turn them. You need to see if they're able to, do some leg, motion or something. We need to increase peristalsis, basically. And then once we start to get the toots, once we start getting breaking the wind or we start getting passage of stool, we know that blockage has been cleared and we're good. And that's it. So high fiber foods after, we need to teach them when they're done and they're better. Raw fruits, vegetables, drinking a lot of water, right? Don't take a ton of laxatives and abuse them, right? That's what causes rebound, constipation, which causes intestinal obstruction, right? So just think about things of this nature, making sure that they exercise, making sure that they walk, right? Making sure that they understand that if we start having oozing or soft diarrhea stool out of nowhere, then we probably have a fecal impaction, and that's a big issue, right? So we need to sit on the toilet. We need to make sure we use things like a squatty potty, right? Like we need to have a bedtime plan, whatever that looks like. All of those things are always going to be that type of deal regarding intestinal obstruction. And I think I have pretty much hit every point that I've ever thought of. If I'm missing something, hey, I'm sorry. All right, so let's go into, I think we're going to do cholecystectomy next. All right, so I put in your pre-op symptoms so that you understand why we'd had this cholecystectomy, right? And now that we are in a post-op standing, the only thing that ever matters is signs and symptoms of infection. So questions are going to be related to patient is post-op cholecystectomy day 2 and has a fever of 100.1. What nursing intervention should we take? And you're going to look for options like notify your healthcare provider, because that's a big deal because they just had surgery and now 2 days post-op, I would expect a person to not have such a high-grade fever. Remember, after a post-op, we're going to have a quick influx of white blood cell count. So I'm not going to be too scared after day 2 of your white cell count going up sky high, because that would be the expectation, because I just got through cutting through the body, right? But if we go past that, any more past that, quite honestly, we start worrying about some serious issues, right? Like we have to really start watching things of that nature. But the most important thing, if we're talking about something like directly after a post-op period, so they've just had this procedure within the last 12 hours or so, I swear that T-tube is the most important thing in the world, because this person is juicy, okay? They're throwing out anywhere from a liter to a liter and a half, which is like 1,000 milliliters to 1,500, or Sometimes it's 5 to 1,000. You know what? Let me go ahead and give this a double check. Give me just a second. Usually it's 500 to 1,000. I'm thinking it's 500. Yep. We're going to say 500 to 1,000 is going to be your answer for that little business right there. That's the expectation. That's like an hourly. So this guy is pretty juicy, pretty nasty, pretty gross. Again, I'm used to seeing anywhere from 1,000 to 1,500. It looks like your book says 5 to 1,000. But yeah, that's basically all you get because it's going to drain. It's been removed, so there's not a whole lot that can go wrong other than infection. So you want to monitor, things like increase in respirations are going to be an indicator for a quick change, and then that's usually followed by temperature. So I would watch for those types of deals and then obvious signs and symptoms of infection. But again, at this period, if we're, a day post-op or whatever, white cells that are, 16 or 17, cool. Like I just got through cutting up on you. So don't let that trick fool you. Make sure that we're watching I's and O's as well because we need to know how much drainage is coming out of this bad boy and if it's getting better or worse. Beyond that, I don't really have a lot with cholecystectomy post-op. Pre-op, there's a ton, right? Like you gotta make sure that they don't get sick. You have to worry about things reflecting pain management, right? Because this stuff hurts big time and there's not a whole heck of a lot you can do without having it removed. Not eating foods that are fatty, right, is a big problem. And then understanding post-op in education that's if you don't have a gallbladder and you eat fatty foods, you're going straight to the toilet. And when I say straight to, I mean by the time you finally finish your food, you were up and going to the bathroom. My best friend in the whole wide world, who I haven't seen in quite some time, didn't have a gallbladder, and I was kind of a jerk, and they were always really smarter than me and wittier than me, right? And they would always give me a once over, but they didn't have a gallbladder. So when we would go out to eat, I would always look at them and give them that face, and he would give me the look of, I hate you. And it was kind of the greatest joke in the whole wide world, and that made me happy on the inside. So thank you for making me prompt that by making me go over this body system. That was cool. So, that's basically I got for gallbladder. Know your signs and your symptoms right? So cholecystitis is going to be a different issue, but know what the signs and symptoms are. Incredible pain. What quadrant? Well, let's see, right upper. Okay, cool. And then what could be a problem? Well, it's probably a culmination of an obstruction and it's building up and blocking up. They can't be jaundice, things of that nature. This is where you need to go. This is the direction you need to hit. Okay, so if I were you, respective to cholecystectomies, I would also include that cholecystitis, okay? And then management of that, because a lot of times cholecystitis doesn't have to become a cholecystectomy, all right? So I would put that into the category of knowledge that you need related to GI, because some of these disease processes you need to think about in pre and post, remember, because we can take some of these guys out. All right, next slide. All right, so let's talk about Crohn's. All of these things are important and specific to Crohn's, period. So Crohn's hurts like the dickens. So here's what it is. It is an inflammatory disease, obviously. It is often an autoimmune disease. It is marked with diarrhea, fever, fatigue, abdominal pain, cramping, blood in your stools, mouth sores, appetite, weight loss. Sounds beautiful, doesn't it? Yummy. Would love it with some, peanut butter spread. That stuff sounds wicked awful, okay? So it's inflammation of the tissues in your digestive tract, which basically gets inflamed and it rips and tears and gets all awful. And this can get so severe that people become, we're talking about massive amounts of diarrhea, we're talking about massive amounts of fatigue and fever. They get so sick that they can actually get septic and die in some cases. So you have to watch out for a lot of things, and we need to make sure that they maintain specific diets. Specifically, don't give them milk, fiber, or dairy. This is a disease of massive amounts of diarrhea with tissue just ripping apart and fistulas forming as it goes. I mean, it's like a freaking Pangea going on in that bad boy, if I'm honest. So don't do those things. Educate your patient. Don't do those things. That's a big no-no. Stool for occult blood. Why? Because sometimes these fistulas make that Crohn's turn into something bigger, like that cancer, or worse. And when we have things like, infectious peritonitis, that's a really, really bad day. And it starts with getting that occult blood to go, okay, there is blood in the stool. Something is wrong. This has been happening chronically over a period of, X amount of years, with periods of latency or nothing happening, but it's still kind of there, but not like, creeping out in the crazy land yet. It's that type of a deal. So after you get the occult blood, you do an endoscopy, be it a colonoscopy, a sigmoidoscopy, whatever that looks like, and then more than likely a barium enema to confirm that. Now, problems with this: you can get fistulas. Well, why is that a problem? Because it causes obstructions. Well, why is that a problem? Because the obstructions, they clot up on each other and they start blocking up walls, and then they perforate the wall. And then why is that a bad deal? Because they get infectious peritonitis. And then that's when you have that hard as a rock abdomen. I'm not talking like puffy bellied liver disease, liver cirrhosis type of belly, because that's pretty tight. No, I'm talking like it as hard as this laptop I'm tapping. It is that scary if you get one of those bad boys. I have had 3 in my life. It is not a great day, and it did not go well in any of them. And those faces I am now seeing in my head from the last time that I saw them, and it turned out well. I didn't know that blood could go out of ears, eyes, and noses, but I learned. How about that? That is what infectious peritonitis turns into. That and their abdomen being gone, and cellophane, and a lot of black in between. I'm telling you, the reason that I'm so hardcore Alexander the Great is because I have lived hardcore Alexander the Great. And it does something to a person, especially when we're all family and we're all blood. And we all should be loving each other instead of killing each other. We can actually do some great things. Okay, I'm not going to get into this tangent because I'm the machine, I've decided. All right, next slide. Okay, I'm pretty sure I'm going to make this my last slide, and I'm going to do a part 3 because GI is way bigger than I thought it was going to be. Oh my God, are you flipping kidding me? GI is ridiculous. This is as big as cardiac. I don't like it. And oh my God, we still have other things to do. Okay, cool. I'm going to breathe. We're going to be fine because we got this, because I have the power, which is He-Man, which is cool because his cousin was She-Ra, and I've decided to take that role. So there we go. All right, so ostomies. All right, cool. First off, there's a couple of kinds. There's a lot of positions you can put them in, but all you need to know is, am I putting it in the small intestine or the large intestine? All right, so the higher up in the bowel system we're going to have, the poop is going to be thicker. Now, I need for you to understand this concept because every single semester, I have to give this concept to people, and every single semester, somebody's got it wrong. And guess what? I was one of those somebodies too, so it's cool. Here's how this works. Shut your eyes. Put that heads-up display in your brain on. Have it firing up, ready to roll. All right, cool. Here we go. So it's very simple. If I eat pizza and the pizza goes into my belly and the acid swashes around with it, it then goes down past that into my intestines. And as it's going through my intestines, and that's my location for my spot, I haven't had a ton of time for those villi and those microvilli, those little fingers and big fingers, to grab those nutrients and break that food down. Therefore, it's going to be harder, which means it's going to be a little bit more hard to swallow, when you're emptying. So just be prepared and it's okay. All right, so the farther down we go, and that's where your ostomy is located, we've had all the time in the world to pull everything off of it, man. It is like an LA riot in the 90s. We just taking everything. We grabbing TVs, we shaking cars. It was a really horrible, terrible thing. And I don't know why that's what was going on in my head. But I mean, that's honestly the torturous situation that's going on in your intestines. So it's quite fair because both are quite awful. Okay, so that's accurate and it's easy for you to see. So, okay, we'll take it. All right, so there you go. That's what that looks like. So now that we know that, what are terrible ideas? Seeds. Seeds are terrible ideas. Why? because seeds have pokey things at the end of them, much like a sugar molecule. And as we well know, sugar molecules that go through your bloodstream like to cut up those walls and just scar them all to heck and back. And that's why we have all the trouble that we have as diabetics. Yikes. All right, cool. We're not going to get into that tangent. That's cardiac. It's not today. Today is a machine. So what are some things that I always see that are related to an ostomy? All right, cool. You have to give them education on this. What type of education? All right, cool. If this thing is beefy and meaty and pink red and shiny, that's perfect. If this thing is purple or blue or has specks of black or is not nice and saturated and shiny, or that tissue is recessed, those are all signs of ischemia. Something ain't right. We got a problem. All right. So this isn't a let the next shift know type of a deal. If you see any discoloration of that nature, we're going through ischemia. Tissue dies fast. You better go get whoever is around. I don't care. That is a get her done and get her done fast. Okay. Especially if it's after surgery. So like if you have surgery and it's like 2 to 3 days and then this starts happening, this happens sometimes, and we don't need to get into the whys behind it. We just need to get into the what do we do's about it, all right? Edema, common if it's a couple of days after surgery. I'm not concerned with that. Redness, common. It's a couple of days after surgery. A potential little bit of bloody blood, couple of days after surgery, I'm cool with that even, okay? We start getting drainage that's too thick, we start worrying about blockage. So we have to check eyes and nose all the time. That's pretty obvious. We are going to expect that isn't going to do very much the first day because it has to settle and get used to the fact that it's new. So if I don't get very much return on the first day, again, another common finding. I'm not concerned with that. What I am concerned with is acute changes that will cause the death of tissue, which would be, discoloration, which is ischemic, or the opposite, which is where it swells so big, it basically crushes its own self. That's a big problem. That can sometimes happen a few weeks to months after surgery, but really is patient induced because they haven't gotten the knack for how to do their stoma care and then get a new pouch on. And sometimes they will glue the stoma accidentally to the surrounding wafer of that pouch. So sometimes they will get really bad tissue issues there. Also, ileostomies are far worse with getting infection than a jejunostomy or anything, a colonostomy or anything like that. A colostomy. Why do I call it a colonostomy? That's because I'm tired. A colostomy. So, and it's based off of the location. So look at the ileostomy in comparison to the colostomy. The ileostomy is right next to what? Well, it's kind of in a beltline location, and it's on the small intestines, which means it can create more damage for an area that can get split in half very easy because it's much thinner and tinier, right? Like you see the size, right? That's what they call it, small and the large. So that's problematic for me. I can do a lot of damage in that area, cause a lot of quick infection, and because it's so centralized into the core of my body, I could really mess a lot of things up quickly. So that is going to conclude part 2. Unless I can magically think of anything in the next 2.5 seconds, and honestly, I can't. Yeah, I don't have anything else. All right, so then I'm going to move on to the other pieces and parts, guys. I'm not going to get it all. There's going to be pieces missing in between, and I am stuttering over myself because, well, I've had 3 cups of coffee, and it's about to be number 4, and I haven't slept in quite some time. So, you get the mad scientist. I love you. Peace be with you and your family. Please give yourself a little bit of self-care time. So says the person who is ironically not stopping, but we don't have time. So do some self-care time and think of me while you're doing it. Give yourself an extra 10 seconds on my behalf, and I will see you for part 3. I'm proud of you guys. You got this.